Good afternoon, everyone. Welcome to the 25th of this series of webinars by the Royal College of Surgeons of Edinburgh's Regional Surgical Advisors, especially aimed at medical students who are locked in and locked down due to the COVID pandemic. Today, we've got a great speaker and a very, very important topic to discuss, acute pancreatitis. And may I introduce Giles Bond-Smith, consultant emergency and hepatobiliary surgeon based at the Oxford Radcliffe Hospitals. My name's Mike Silva. I am also a hepatobiliary surgeon based in Oxford and also a regional surgical advisor. Giles is one of a new breed of surgeons who pioneer emergency surgery as well as being highly specialized in hepatobiliary surgery as well. And he is fast making a name as an expert in the management of pancreatitis in our region and around the country. And I'm sure you'll really enjoy his talk. Don't forget that you have a Q&A option at the bottom of your screen. Please use that to ask questions. I will try and answer some of them live and then leave the more important or the most voted in by you with your thumbs ups app or application that you have for Giles to answer at the end of his talk. Also, remember that we have another session next Tuesday and we'll be talking about management of blunt trauma to the chest. But to start off with today's talk, Giles.
Mike, thanks so much for those kind words. It's fantastic, thank you. So here, to everyone, talking about acute pancreatitis, and we're going to talk about how to make a diagnosis, what investigations you should implement, and then talk about some of the management strategies. I've got 20 minutes. It's a massive topic. So I've really tried to condense it down just to those salient features that you guys will find useful when you're on call. So first of all, we've got to make a diagnosis. In 2012, the great and the good all got together in Atlanta and came up with a slightly revised criteria for diagnosing acute pancreatitis. You need 2 out of the following 3 things. So first of all, you need a good history, and a history that's consistent with acute pancreatitis and some clinical signs consistent with acute pancreatitis. Gradual onset, epigastric pain, radiating through to the back, associated with nausea, vomiting, relieved by leaning forwards. You can look all of that up. It's in any standard surgical textbook, but that's the first point. Second point, either an amylase or a lipase level. In the UK, typically we use amylase. There's got to be 3 times the upper limit of normal. That's the second feature. And then the third is that you need some sort of imaging to demonstrate acute pancreatitis. And you need 2 of those things. So maybe the amylase level's not raised, at which point you get a CT scan, which then demonstrates acute pancreatitis. That, with a history, is good enough for you to diagnose pancreatitis. Just bear in mind that around 5% of patients will have a normal amylase lipase at the time of presentation. That's for a variety of reasons, but you've missed the peak of when the amylase goes up in acute pancreatitis. It's really important when you're seeing patients with pancreatitis to get an underlying etiology. What is the cause of the pancreatitis? So in the UK, typically it's gallstones, make up 50% of cases, alcohol about 25%. That's important because if someone's got gallstone pancreatitis, they need their gallbladder removing. And that's part of your management plan, that you should be referring these people on for an acute cholecystectomy within a couple of weeks of their acute pancreatitis episode to have their gallbladder removed and reduce the chance of it happening again, all right? Same with alcohol. Getting these people out into alcohol awareness support systems to try and get them to reduce their alcohol intake and mitigate their risk factors. Everyone knows the mnemonic, I get smashed. typically the S in there is scorpion bites, but what I would actually put in there is smoking. There's good evidence now that smoking is as bad for the pancreas as alcohol, and one cigarette has a half-life of about 24 hours. So if they're smoking more than one cigarette a day, that's not good enough. Saying, doctor, I've reduced from 20 to 10, doesn't matter. They're either don't smoke or they do. And what you've got to try and get them to do is not smoke. I put some other causes down there just so that you can really flesh out and understand the causes of pancreatitis, because you can alter how these people, their management plan according to their underlying cause. Just remember, ERCP, the cause behind an ERCP causing pancreatitis is barotrauma. It's the retrograde flow of the contrast into the pancreatic duct that raises the intraductal pressure of the pancreas, causes the pancreatic acinar cells to rupture. They release their precursor enzymes in the wrong place. They get activated. You get pancreatitis. So the buzzword there for ERCP is barotrauma. Look at the other drugs that they're on. Just make sure that they're not, and can you give them something else? Having taken a history, done the blood tests, worked out what their underlying cause is, you should score the patient. I personally recommend you use the modified Glasgow IMRI criteria. The mnemonic for that is pancreas. You can see it there. Again, it's in any good surgical book, actually any good medical textbook. People do talk about Ranson criteria. It's only related to alcohol pancreatitis and not validated in anything else. So perhaps move that to one side. Patchy 2, it's good at working out multi-organ failure, not specific to pancreatitis. Balthazar was a radiologist who named a CT severity index scoring system for pancreatitis after himself. Again, it's not that useful in the assessment of acute pancreatitis because typically it takes a week or so for the CT findings to become apparent. Therefore, you're left with Glasgow IMRI, the modified Glasgow score. And on that, if 3 or more, you blow positive on three or more of those, you should be speaking to ITU HDU, because actually what you've got is you've got someone who's in multi-organ dysfunction and should be in a critical care setting. He says, trying to move on. So blood tests, very briefly. Amylase and lipase, they're only diagnostic. You do it once and once only. I don't want to see repeated amylase levels. Oh, but the amylase is getting better. It's got nothing to do with it. It's a diagnostic exercise. It's like doing an X-ray for a pneumonia. There it is, pneumonia, can see it. Thanks very much, we treat. Don't keep doing serial amylases, it's meaningless. Liver function test, so the ALT, if it's over 150, it's got a good predictive value of predicting gallstones as the cause. CRP, if it's less than 110, this is based on a French paper, if it's less than 110, you're unlikely to develop necrotizing pancreatitis. If it's over 250, you're more than 50% likely to develop necrotizing pancreatitis. Just really simple test that gives you some feeling for how unwell the patient's going to be. We talk about hyperlipidemia as a cause. It's actually hypertriglyceridemia is the cause. Hyperlipidemia is what we see in the blood test. It's a secondary phenomenon to the hypertriglyceridemia causing pancreatitis. Pancreatitis then causes hyperlipidemia. So we should use triglyceride levels not as part of a lipid profile. Ultrasound scan, it's great for looking at gallstones, much better than CT, much better than MR. What do you do if the ultrasound scan is negative? Well, you do it again is the upshot, and you should do it again before the patient leaves. This is the reason that ultrasound is very dependent on who's doing the ultrasound and whether the patient's fasted properly or not. we should be getting that ultrasound within 24 hours to exclude gallstones as a cause for pancreatitis, because if they've got gallstones, they need their hot gallbladder doing, or at least getting their gallbladder out in 2 weeks. CT, everybody comes in with abdominal pain onto a surgical unit, pretty much gets a CT scan. Well, in pancreatitis, we're actually doing it to exclude other possibilities of significant abdominal pain, perforation, ischemic bowel, etc., etc. We need to get contrast enhanced scans, so please make sure that you request a pancreatic CT which has contrast in it, but also make sure that you check their renal function and that they're able to have it. Down the line, CT is very good at helping us work out the extent of necrosis, any pseudoaneurysm formation, or any peripancreatic fluid collections that have become pseudocysts that we could treat or could be causing problems and we need to manage. The UK guidelines suggest that we should wait between 6 to 10 days after admission before getting a CT. We get the CT early to exclude other intra-abdominal pathology, not to confirm pancreatitis. It takes a while for the pancreatic signs to show up on CT. MR, it's a good alternative to CT. It's great at looking at the fluid around the pancreas, working out, is it solid? Is there debris in there? Is it mainly liquid? Which aids how we drain that fluid collection should we need to. Also, I'm thinking I need to do the gallbladder. That needs to come out. So MRCP is great at looking for anatomical variants, which could complicate your laparoscopic cholecystectomy, but also could be a cause of your pancreatitis, pancreatic divisum, I'm thinking of there, amongst other things. You can't get an MR at 2 o'clock in the morning. Well, not in Oxford, you know, but generally in the UK, it's very difficult to get an MRI scan in the middle of the night. So CT, probably the way forward. It's easier to get looking at it long term. Some of you may have heard of endoscopic ultrasound. This is where an endoscopy is passed, which has got an ultrasound probe at the end. This is fantastic for going into the stomach. We can assess the biliary tree. Remember, ultrasound is the best modality for looking for gallstones, microlithiasis, intraductal stones. It's just brilliant. And here we are passing it down into the stomach and looking just next door to the stomach where the biliary tree is and the gallbladder. So you can pick up small stones, microlithiasis, all right? But also you can look and see that peripancreatic fluid collection that may be produced as a result of pancreatitis that needs draining. You can punch a hole through the stomach into that collection, so long as there's a wall, so into a pseudocyst. Quick definition, remember, peripancreatic collection, once it forms a fibrous wall, that's your pseudocyst. So endoscopic ultrasound is able to go down, confirm that you've got a pseudocyst, but actually can also punch a hole in the stomach, place a stent, a little drainage tube, and allow us to suck the fluid out of that pseudocyst and treat it. It's called an endoscopic cyst gastrostomy. But you guys want to know how to manage this and a few little top tips. So the first thing is fluid management. So you've got your patient, you've got your causes, you've booked them for theatre, but now you're actually into the real meat of it and you're trying to get these people better. The first thing is fluid management. These people can be vomiting a lot and they can become very, very dehydrated very quickly. 2 studies, look, I appreciate the numbers are not great, 41 and 41. Pretty awful, but it's the best we got at the moment. What those studies demonstrated in the setting of pancreatitis, we should be using Ringer's lactate, which is code in the UK for Hartmann's effectively, as physiologically normal crystalloid as possible. The reason for that is that pancreatitis causes quite a big SIRS response, systemic inflammatory response syndrome, which gives you effectively a metabolic acidosis. Now, Hartmann's contains lactic acid. It contains lactate in the fluid, which gets broken down peripherally by carbonic anhydrase, as you'll remember, into bicarbonate. So actually, Hartmann's really works well as a physiological buffer against the SIRS response. And look what those two studies showed. Lower SIRS rate, lower inflammatory levels, and so we should be using that so we should be using Ringer's lactate or Hartmann's as our fluid. Overall, there's no difference in outcomes. You know, the same number of people died, the same number of people went to ITU, etc. But we did see lower SIRS and CRP levels. Early goal-directed fluid therapy. So this reduces your intensive care stay, reduces multi-organ failure, death, and swelling within the abdomen, causing abdominal compartment syndrome. So that's why that scoring system is important. 3 or more on that modified Glasgow scoring system, and you know what? They're heading to critical care, HDU or ITU, at which point you're going to tell them to use Hartmann's, resuscitate them in a goal-directed fluid therapy manner to restore a good circulating volume with a hematocrit of over 35 if possible, and you'll lead to better outcomes. Antibiotics. Patients that come in with pancreatitis, they're tachycardic, can be hypotensive, can have a high temperature, high white cell count, high CRP. Everyone says they're infected. They're not. It's a big SIRS response, all right? So there's been a lot of studies that have looked at this ad nauseum, and antibiotics have been shown not to prevent infection within the pancreas, especially the necrotic pancreas, and it doesn't reduce your outcome. But what it most definitely can do is breed resistance, which means that if you've hit your patient early with too many antibiotics, they've bred resistance, and then the patient gets infected necrosis, you're in trouble because you won't have any antibiotics to sort that out. And more importantly, they'll start developing fungal infections such as Candida. Nutrition. So nutrition is probably the single most important thing in the acute stage of pancreatitis. We forget about it all the time. We bring these people in, we make them nil by mouth, and that's job done. Can't do that. The idea is that during pancreatitis, the pancreas secretes this sort of really nasty endotoxin, which stimulates SIRS response, leading to multi-organ failure. And if we can get some gut sort of nutrition into the lumen of the bowel, the GI tract, we actually find that that endotoxin is not taken up in the same numbers. Now, the reason I've put there is not being supported by clinical trials is because the clinical trials haven't quite completed yet, but it is looking like if you can reduce endotoxin absorption, then you can blunt the pancreatitis effect. So when best to, and how to give nutrition? Well, if it's mild and the patient's not vomiting, we now say just eat. Let them eat and drink. It's fine. If it's severe, do you know what? We still say eat and drink, so long as they're not vomiting. But if they are, start thinking about getting some TPN, right? Early doors, because at the very least, they're going to develop an ileus. Most people can tolerate an NG tube. There's NG, NJ, that's a story that's going on. It's safe to do NG feeding. You don't have to do NJ feeding. The theory was that if you could float a tube past the pancreas, you would rest the pancreas. This has not been shown to anymore to really work for a variety of different reasons outside of this brief lecture. Just know you want to give them enteral nutrition. If you can't give it enterally, give it NG. If you can't give it NG, give it NJ. If you can't give it any of those, give it TPN, IV. We instigate, as the Newcastle Free Royal London, what's called dual fuel. So we very quickly get them onto intravenous nutrition, which then takes the pressure off. And then we slowly introduce enteral feeding as they get better. Octreotide, there's 5 big randomized controlled studies looking at the use of octreotide. This is a somatostatin analog. which we thought could potentially switch off the pancreas. In the setting of pancreatitis, there is no justification for the use of it in acute pancreatitis. That's all I'm going to say there. So please don't start giving octreotide as a method to turn the pancreas off. It doesn't work for a variety of reasons. Your patient comes in, they may well have deranged liver function test. They may be significantly jaundiced. A stone may be stuck in the bile duct. The back pressure causes that barotrauma that I was talking about. The head of the pancreas may swell and compress the bile duct. The patient is jaundiced. If they are, they need an ERCP, or they need some sort of biliary drainage, all right? If they're not jaundiced, then please don't start referring for ERCPs. They don't need to be done right there and then, all right? We can talk about at a later date for the non-obstructing stone. Does it need to come out, yes or no? That's a bigger question. If they're not jaundiced, they do not have an obstructive biliary system, they do not have a high pressure system, they do not need an ERCP. However, if they do, it is almost a medical, in fact, I'd go as far as to say it is a emergent situation. It's an emergent situation to decompress the biliary system in the setting of pancreatitis. I put 4 things just to think about in people with pancreatitis that can, complications, I've called them, I suppose they're outcomes. 1, hemorrhage. You can get pseudoaneurysm formation in pancreatitis. What happens is you get an unexpected drop in HB, and that's called the herald bleed. The little pseudoaneurysm has had its warning bleed and then stopped. The next bleed will be torrential. So if you see an unexpected HB drop, consistent, you're worried about a pseudoaneurysm, you need to get an urgent CT angio. Thrombosis formation. The pancreas irritates the splenic vein, portal vein, superior mesenteric vein. You can get thrombus formation through that. The evidence would suggest that we don't necessarily anticoagulate straight away, but local policy may change from that. The medical team seem to be much keener than the surgical team to start anticoagulation. The reason that we don't is because we know when the pancreatitis settles down, almost 100% of the time, the thrombosis disappears. You can get pancreatic duct strictures, as you would expect, and they may need stenting or a surgical solution down the line. And you can get these peripancreatic collections, which once they form a wall, become a pseudocyst, and then they can become problematic, irritating the stomach, making patients vomit, giving them a gastric outlet obstruction. And that needs to be treated, and it can be done via endoscopic ultrasound. And that cyst gastrostomy, it can be a transgastric drain, or ultimately we can do a surgical laparoscopic or open cyst gastrostomy. What's the future? Well, there's some trials that are going on at the moment. The Rapid Eye trial is run out of Liverpool, great study. I'm looking at the development of a monoclonal antibody, STAT2 gene-based, to try and turn off pancreatitis. But ultimately, we need to get a better understanding of nutrition in acute pancreatitis. So my takeaway messages are: 1, Atlanta criteria, make the diagnosis. 2, assess the severity. I would suggest modify Glasgow. 3, find out what the cause is, because that dictates your management plan. And 4, think about ultrasound early. CT, 6 to 10 days, unless you need to exclude something else. MR has a role to play. And then think about the complications that can occur so that you don't get caught out. At the end of the day, if someone's unwell, do not be afraid to go to your critical care team and ask for early input, because these people can look well right up until the point that they're not. That is acute pancreatitis in sort of 20 odd minutes. Mike, thank you very much.
Brilliant, brilliant, Joyce. As expected, we are getting positive feedback even now as we speak. So there must be something positive in what you're doling out there. Excellent. Just to get the ball rolling and ask a rather important question. You did mention CT scan as an initial investigation if you want to exclude any other cause, especially in the acute presentation. But the majority of patients don't end up getting CT scans. Which patient would you say requires to have a CT scan, although you're sending the patient home?
Oh, Mike. So the issue that I have is that if a patient requires a CT scan urgently, you've got to ask them, well, they shouldn't really be going home, because what's the abdominal pain that is that bad that requires an urgent CT? That if the CT is normal, why are they going home? You should wait.
No, this is the interval scan at 7 days or so.
Oh.
So all patients don't get scans as an interval, but some patients need that.
Oh, sorry, my mistake. Sorry. Yeah. So those patients at 6 to 10 days that have not settled. So it's typically at day 6, 7, you're worried. So the patient's gone home. You've excellently managed their pancreatitis, but you're worried about a degree of pancreatic necrosis. That's the first thing. If they've had severe pancreatitis, they're at risk of getting this pseudoaneurysm formation from any of the blood vessels that run behind the back of behind the pancreas or in the neck. So typically the splenic artery, the GDA, hepatic arteries, those branches. Anybody that's got persistent nausea, vomiting, because what you're trying to look and see is has the pancreas created fluid around the pancreas that's going on to form this sort of pseudocyst formation. You can get early wall formation in peripancreatic collections, which push and move and kink the duodenum and the outlet part of the stomach, which will make people feel sick on eating pretty quickly. So you're looking at that point, is there anything in the pancreas to do with the pancreas that I can treat? Pseudoaneurysm, they need embolizing. Pseudocyst formation, symptomatic, that needs draining. Necrosis with infection, that may need resecting. So it's these kind of issues that you're looking for at day 6 to 10. But actually, they're not really at home necessarily. They're typically still on the unit.
Okay, so that answers the question. Thank you. There's another question that's rather interesting and intriguing, and that is, if a patient has blunt trauma to the pancreas and duct disruption and presents to you with pain, would you be then treating acute pancreatitis, or is this a pseudocyst you're dealing with?
Ooh. Oh, how long have we got? Right. So blunt trauma to the abdomen. What happens is the pancreas gets pushed against the spine and fractures. The spine acts as a fulcrum. The pancreas bends across it and snaps. And typically it snaps at sort of like the neck body part. At which point, either it's a contained leak, small leak around, that's fine, we can deal with that. Or I've actually seen it where it can separate. Now, it depends on how old the patient is, how unwell the patient is, and any sort of other past medical history as to how you manage this. Because the first thing you're going to see is a sort of acute pancreatitis. Well done, excellent for pointing that out. Then you're going to see a pancreatic leak. Now that pancreatic leak, if it stays contained around the pancreas, will form a wall and may end up shrinking down, scarring, and you're okay. But if it doesn't, then you're left with a problem, because the distal end of the pancreas that plugs into the tail end near the spleen, that is still live, viable, and is going to produce pancreatic juice. and it's not going to be able to drain into the bowel the normal way. So sometimes what we have to do is we have to do a distal pancreatectomy, take that away. The head neck bit, you have to sew up the back end, leave some drains, and see how they go. That's quite extreme. So we always try and manage conservatively in the first instance. Second instance, see if you can put a pancreatic stent. That's something that we can do. And I've seen that, especially in young children, work really, really fantastically to allow the juice to drain in the normal manner. And if that all fails, then you're going to end up with a distal pancreatectomy. But pancreatic trauma is a big subject and complex, but it's great for thinking of it. Whoever asked that question.
Brilliant. I'm going to ask 3 quick-fire questions because we've got loads of questions that are poured in. But this one I think is quite useful for medical students and foundation trainees. If your ultrasound scan is negative and you're still suspicious of gallstones, is there a role for MRCP? Asked Archie Lodge from Oxford.
Archie Lodge from Oxford. The best modality for looking for stones is ultrasound. So our radiologists here in Oxford constantly sort of say, why'd you get an MRCP? You should have gone for the endoscopic ultrasound. And Archie from Oxford, you can get an endoscopic ultrasound in Oxford. So that's the best modality. Now, people that are not in Oxford and around and not everywhere has endoscopic ultrasound, you can get an MRCP and you will see a slight layering. But what I would do first is I would repeat the ultrasound scan a few days later, ensuring the patient has fasted for a good period of time. So that gallbladder is really distended. And then when the radiologist, the ultrasonographer moves the patient, they can see the stones moving around in the gallbladder. Does that answer it, Mike?
It does. Brilliant. Two quick questions. In the acute phase, when you're suspecting pancreatitis, you said you should do a serum amylase and also mentioned lipase. Which of the two is more important? Which of the two are more relevant in the current context of NHS practice?
Amylase. Just do amylase. It's cheapest, it's ubiquitous, but you do it once, you can do it once only.
Perfect. And the last question, and again, it's relevant because it gives an understanding as to what you're treating and what exactly your objectives are. James Manning wants to know, how important do you think is it to administer Hartmann's, considering it ameliorates some of the biochemical abnormalities like the CRP and SIRS, as you mentioned quite eloquently in your presentation, but it doesn't really result in any obvious change in the outcomes. By outcome, I think he means the severity of the pancreatitis.
Yeah, sure. So, yeah. But go back to those numbers, right? Look at those studies. Those studies were small studies done. That's the first thing. The second thing is that in pancreatitis, you get massive leaky capillary syndrome. So if you start hitting with alternatives such as colloids, etc., you get the colloids leak out through the leaky capillaries and then start acting against you. So we don't really want colloids. Now, in terms of other crystalloids that you could use, normal saline, etc., often in pancreatitis, you have to give quite large volumes of fluid because these people are so intravascularly deplete. And if you give a lot of normal saline, then you're going to end up making them hyperchloremic, and there's other sort of abnormalities that can happen regarding that, which is why we like Hartmann's, because it's as physiologically normal as we can get. It's safe. And that's ultimately what we just want to be. We want to give something, be able to give it in good volumes and not have to worry about any added side effects. And in a nutshell, it has the least out of all of them.
Brilliant.
I would really strongly recommend Hartmann's in the acute setting.
Thank you, Giles. That's excellent. I think that's as much as we can get in this brief period. I think I'm hoping that the participants are a little bit more informed and wiser when it comes to managing pancreatitis, and thank you very much. Just to remind our participants that next Tuesday's topic is managing a patient with blunt